My name is Dr. Wes Ely, and I am very thankful to come here from the United States to kick off this session on the PADIS guidelines. The guidelines, by way of history, went through a evolution, being called first the SAG guidelines, sedation analgesia guidelines, and then the PAD, pain, agitation, delirium guidelines, and now the PADIS with immobility and sleep as part of the pain, agitation, and delirium picture. When I was listening to the previous lecturer, who was excellent on steroids and critical care, it dawned on me to put this session in context of the rest of what you are learning today. So if my arms here are the arch of critical illness, and this is when somebody is beginning to get sick, they level off, and then they recover. Years ago, 20 years ago, we thought that the back end of critical care was around day 5, day 6, day 7, when we would start pulling off the interventions that we had put on board to try and save someone's life. What we have learned in the past 20 years of research and randomized controlled trials is that in this arch of critical illness, the back end is not over here on day 5 or 6, but actually over here on day 2 of critical illness. And so these guidelines, the pain, agitation, delirium, immobility, sleep guidelines, we used to think of employing these sorts of aspects of care way back on day 5, day 6, but now it is clear to us that we will improve survival and improve the quality of life and survival if we begin thinking with a long-range viewpoint and lens on our camera way early in the critical illness of our patients. So when somebody first comes in sick and they're in shock and sepsis, our first thought is, what do I add to their care, like a ventilator or dialysis or vasopressors or steroids, to try and help save their life? But the irony is that even though we need to add those things to their care to help save their lives, as soon as they stabilize, we then immediately have to train ourselves to start removing those interventions, because what was good yesterday can be dangerous today. Okay? So that's a major concept that I want to impart into your mind as you begin to pursue critical care of your sickest patients, is that just because something was needed yesterday doesn't mean that it's good for the patient today. We leave on sedation, immobility, mechanical ventilation, and all of these types of interventions way too long for our patients. And we cause harm that we refer to as the post-intensive care syndrome. By leaving on these interventions for extra days when they're no longer required, we actually create 2 new diseases for our patients, which are the neck down problem of ICU acquired weakness, which is muscle and nerve disease, and the neck up problem of delirium and dementia. So what I'm going to go through with you today are 3 points that will help us to do a better job of handling these circumstances, and it will be all within the context of the PADIS guidelines. And then when I'm done, the following speakers will build on my general talk with more specifics about nurses and sedatives and so forth. Okay? That's the basis. Now, I want to disclose that I have received help in giving international lectures like travel expenses and such from Pfizer and from Orion. I do not have stocks in their companies or care if you use the products, but it is important for me to disclose that potential conflict of interest. Anything that I say in this lecture will be evidence-based and will be restricted to the peer-reviewed literature rather than my opinion. This is a picture of about 70 or so people in my research group. We have 90 people in our research group at Vanderbilt University in the Center for Critical Illness, Brain Dysfunction, and Survivorship. And our website is a source of educational material for you. It is icudelirium.org. So if you want to go further into any of the concepts that I talk about today, you can just Google ICU delirium, and you will find our website, which is icudelirium.org. This is a paper that I published a few years ago in the New England Journal of Medicine. And this paper began to teach the world what we were learning about the acquisition of dementia after critical illness. What you can see on this graph are the data that we found in the brain ICU study, whereby we followed people for a year and realized that instead of being here in the normal range of cognition, people were way down in this range around traumatic brain injury and Alzheimer's disease. This was very alarming for the critical care community, especially when they realized that it was associated with atrophy on the MRIs of these patients. And what we learned was that delirium was a predictor of this atrophy and of this dementia. We also learned far left on this graph that this was not just occurring in people who were over 65, but actually also occurring in people who were in their 30s and 40-year-old people. So imagine a 32-year-old coming in the ICU with lupus and then getting pneumonia and being on a ventilator and having to go through ECMO. And that woman had normal cognition and then leaves the hospital with an acquired dementia. Or a woman who is perfectly normal and just gets community-acquired pneumonia or gallstones or some other surgical issue. Well, these are the things that are leaving people with a dementia after critical illness. And what we believe is happening is that during times of delirium, shown on this graph here, that the longer someone stays delirium along the x-axis, the higher their risk of dementia is on the back end of their critical care. The dementia essentially is a phenotypic example of what is happening inside their body with neuronal cell loss. So the fact that somebody can't follow your commands, can't organize their thinking, and has this ongoing delirium is an external manifestation of the fact that their neurons are suffering and dying indeed, and then that translates ultimately, weeks and months later, into this atrophy. The things that cause delirium and critical illness can be summarized basically down into diseases, drugs, and environment. And if you take these diseases, drugs, and environment and make them into a tool, you can help remember what to do for your patients. We call this the Dr. Dre. Dr. Dre is a famous rapper in the United States, and he has the Beats earbuds. So I wrote to Dr. Dre and asked him if I could use his picture for this mnemonic. He did not write back to me, so I'm taking that as a yes. But we use this mnemonic every day in the ICU, and when someone is CAM ICU positive, that's a tool that you can use to measure delirium. That or the delirium screening checklist, either of those two tools is fine. But when someone tests positive for delirium in the ICU, our nurses and I run through this quick list. What diseases could be causing it? Sepsis, COPD, CHF. What drugs should be removed? And what environmental factors like sleep, eyeglasses, hearing aids, light, etc., are creating this problem for the patient. And so we try and address those, and more often than not, we can help the person have a shorter duration of delirium. Now, yesterday, when I was rounding in the ICUs here, I was allowed to take a picture of this excellent example of how we set a goal for our patients with regard to mobility. When we do set a goal like this, it helps us as a team to realize that we have to get our patients back to the land of the living. We cannot let them stay over here. Unfortunately, in the ICU, all too often, our patients do sit over here and lie in the bed, not using their legs, not using their body, and the more immobile a person is, the more pronounced their delirium gets. In fact, mobility, even like this, becomes an extremely good way of reducing duration of delirium. Now I'm going to give you two numbers to remember. Every additional day of delirium creates or adds to a 10% rise in the risk of death by 6 months, and every day of delirium increases the risk of cognitive impairment by 35%. So 3 days of delirium increases your risk of dying by about a third, and pretty much will predict that you're going to have some degree of cognitive impairment on the back end of that critical illness. Now, that's the first major point I wanted to make out of the 3 points I'm going to make. And that was that we have a public health problem in ICU medicine. And our public health problem is that we are guilty of paying attention to what got the patient into the ICU and ignoring the new acquired problem of brain disease and body disease that the patient develops under our care. That's the first point. The second point is that I'm going to give you an example of how we have made errors in our thinking of how to handle the problem. And then the third point I'm going to make is how we should be handling these problems. So, which gets us back to the PADIS guidelines. 40 years ago, this doctor, Ned Kassem from Harvard, thought it would be a good idea to use antipsychotics for delirium. Quickly, antipsychotics like Haldol and now risperidone, ziprasidone, quetiapine, etc., have become usual care for treating delirium around the globe. In fact, this survey, which we published 2 years ago, shows you that around the world, most people, 60 to 80% of doctors, nurses, etc., use antipsychotics for delirium. When articles came out in the New England Journal and JAMA in 2005 saying that these drugs were increasing the risk of dying, I began to be concerned that we didn't really know what we were doing. So I designed a randomized controlled trial and went to the National Institute of Health in the United States and asked them for $9 million to do a proper randomized trial. That trial became the Mind USA study, and we published this in the New England Journal last year. The data from this study, which had about 200 people per group in 3 different arms, randomized to either receive placebo, Haldol, or ziprasidone, which is an atypical. The results showed us at the end of the day that whether you were using Haldol, which is a D2 blocker on the left, or an atypical antipsychotic, which is, in this case, we used ziprasidone, which is on the right and shows you a multifactorial way of approaching neurotransmitter abnormalities in the brain. Neither of those drugs, as compared to placebo, improved duration of delirium or coma. In the end of the day, the patients had no clinical difference in the amount of delirium or coma they were experiencing if we took an approach of writing for an antipsychotic. In addition, we did not see differences in survival or in these commonly sought after clinical improvements, such as ICU discharge, time on the ventilator, or hospital discharge. Because of these conclusions, I began to realize that for many years I had been relying on these drugs as my answer to what I was going to do to help a person. And when a person was sitting in front of me and the nurse said that she was CAM positive or delirious, I would quickly write for a drug. And I would think at that point that my job was done. Well, I'm glad these data were negative, if for no other reason that it made me wake up and realize that the most important thing that I can do for a person when they're delirious is to focus on non-pharmacological aspects of their care. So, this quote, "A long habit of not thinking a thing wrong gives it a superficial appearance of being right," by Thomas Paine in Common Sense. For 40 years of modern-day critical care, we thought it was okay to be delirious. And even when we thought we were going to try and reduce the delirium, we thought it was okay to write a drug, like an antipsychotic, to reduce the duration of the delirium. Now we know differently. What will we do about it? Well, I don't want to go on too long, and I want to keep us on schedule, so I'll jump to my third and final point of the talk, which is that the PADIS guidelines support the concept that a multifactorial approach to patients' delirium is the most robust evidence that we can go by. That is that in this circumstance, we used 40 Lancet, JAMA, and New England Journal papers, and another 350 lesser journals, but still important data, to build something called the ABCDEF bundle. This is a 6-pronged bundle which has been shown very robustly, and I'm going to show you the data, to improve survival, reduce length of stay, reduce ICU bounce backs, and help people go home more safely. We also know that the more we adhere to this bundle, we spend less money. We save money. So these things are very important. I am, this morning, since I'm in Seoul and I wanted to see some of your beautiful city and country, I went for a 4-hour hike this morning up in the mountains outside of Seoul. You have a beautiful place to live here. And in my walk, I listened to Erickson's biography of Leonardo da Vinci. And one of the chapters about Leonardo da Vinci is about him being a scientist and him developing the scientific method. In that chapter about Leonardo da Vinci, he has recorded in his notebooks, his extensive thousands of pages of journals that we have from Leonardo da Vinci, that it is important to take scientific observations and repeat them over and over again to see if we get the same answer. And that only after repeating our testing and getting a consistent answer should we be convinced that this is the way to go. So after having heard that, I thought that I would include that point in this lecture today with you, because that is exactly the approach that we took with this bundle. I resisted believing that this was really the way to go until I had seen it proven over and over again. So my point is as follows. Individually, each of these points, SATs, spontaneous awakening trials, where we turn off sedation and allow somebody to wake up, SBTs, spontaneous breathing trials, where we turn off the ventilator and see if somebody still needs it, has been proven in multiple randomized controlled trials individually. We've had multiple randomized trials showing us that GABAergic drugs are less advantageous to patients than other approaches. Benzodiazepines have been subjected to 30 randomized controlled trials, and they have not proven superior to their comparator in a single randomized trial to date. We now have a lot of data on reducing delirium, and we know that things like early mobility will reduce delirium, or that drugs other than GABAergic drugs like alpha-2 agonists, dexmedetomidine, can reduce delirium and coma duration and improve the ability of the patient to cognitively follow nurses' directions or reduce time on mechanical ventilation. And we actually even have data from family trials in the New England Journal and JAMA that show that family incorporation to our patients' survival is important. Now, one of the things that I've learned here by going to your different ICUs is that most of your units are open, meaning that they have lots of patients in the same big room. And so this does present a challenge to you about how will you incorporate families into the lives of their loved ones while they're going through critical illness. And I sympathize with this, but we have to work towards some solution because these people need to see their husbands and wives and children more than just 2 30-minute sessions per day. And many of the ICUs in Korea still have 2 30-minute family visitations per day. And I think that's very hard on patients. It's very hard on families. And what we've learned from this bundle is that when you then put those individual pieces into a single program of safety, that we see even better outcomes. So let me show you that there are lots of literature on this bundle now. And this paper here, number 11, is one where I summarized the world's literature on how we created the bundle, if you wanted to find a good summary. And for example, numbers 16 and 17 are written by nurses and published in Critical Care Nurse in 2019, which are great examples of how to do this at the bedside in real life. Because it does involve changing the culture of how we approach our patients. For example, instead of having the nurse over there and the doctors over here when we round, one of the things that we learned in the Society of Critical Care Medicine's program was that when we have the nurse and the doctors talking to one another on rounds and presenting the bundle to each other and talking out loud, it works a lot better. And the patients get further along faster. So I have watched many, many different types of ICU cultures. And the most progressive cultures, which I think you could adopt here in Korea, are that when you get to the bedside of a patient, the first person to talk is the nurse. And the nurse will quickly present in 30 seconds the elements of the bundle and other things that he or she is worried about. And then the doctor will hear that directly from the nurse, including target RAS, actual RAS, CAM, and drug, these 4 critical pieces of data that I call the brain roadmap. Where's the person's brain? Where do we want it? And how did it get there? Target RAS, actual RAS, or real RAS, CAM, and drugs. When the nurse presents this information, we have the inability to ignore it. We have to pay attention and wake the patient up and get them out of the bed and move them further along in their recovery. If we don't talk about delirium on rounds, we miss it 75% of the time. Is it okay with you if I miss your patient's shock? Is it okay with you if I miss your patient's hypoxemia? And yet delirium is a more robust predictor of outcome than shock and hypoxemia. The duration of that delirium controls the patient's prognosis. So here is a woman whose picture I have received permission to show, who had necrotizing fasciitis of her face. She had 21 surgeries. Every single day that she was intubated, I was walking her in the ICU. And we were reporting on the bundle, her target RAS, her actual RAS, her CAM result, the drug she was on, what she was doing with her spontaneous breathing trials. And when she failed over and over, we got her out of the bed on the ventilator and walked her. So that the very first day that she passed her SPT, we extubated her, and here's a picture that I took with my iPhone. Way down the hall from her room, which was way back here. The only reason she was able to walk that distance on that first day off the ventilator was because we had been walking her all the previous days as well. Now, that is a change from the way that I used to practice medicine. I did not practice that way when I didn't have gray hair. But my gray hair now has changed the approach because of the data. Here is a woman failing her SPT with her ventilator shoved in a grocery cart with her husband holding her arm lovingly. The patient's family with her, supporting her, providing mental and physical strength while she walks to use her body so that she can have less delirium and less post-intensive care syndrome. This is the E, the F, and the D of the bundle. It's also the C, because we paid attention to what drugs she was on and avoided the propofol and benzos. It's also the B, because she got both the SAT and the SPT. And it's also the A, because her pain is well controlled. So these are the interlocking elements of the safety bundle that we view as the pilot's checklist before you fly the airplane. Now here are the hardcore data. I told you Da Vinci wants us to prove it to ourselves over and over. So after we had done single center trials, these data were from the first multi-center study of 6,000 patients, 6,000 medical and surgical ICU patients, adjusted for age, Apache 3, and mechanical ventilation. And what you can see is that as you go up in the dose or the compliance of the bundle from 20 to 30% or 50 to 60%, steadily, the bundle compliance is an independent predictor of survival and of freedom from delirium and coma. But let's not be satisfied with 6,000 patients here. Let's move on to 15,000 patients. Let's look again, the way Da Vinci said that we must. And in this ICU Liberation Collaborative by the Society of Critical Care Medicine, we used hospitals all over the United States to study for 2 years the implementation of the bundle. We actually enrolled 15,226 patients at 68 ICUs and 10 pediatric, and we adjusted these data for 18 a priori defined confounders. So at the end of the day, the 5 or 6 graphs I'm about to show you are showing the relationship between bundle compliance as an independent predictor of ICU discharge. And as you go up from 0 to 30, 50, 60, 80, and 100% compliance, you see a steady increase in the likelihood of being discharged from the ICU. Wouldn't you want that? Don't we want that for our patients, to get out of the ICU faster? But that's not good enough. We want them to get out of the hospital faster, and we saw that. And we want them to die less. So here's reductions in survival from better compliance. And we want them to have less coma and delirium and less restraint use. All of these things repetitively shown with the use of the bundle in over 20,000 human beings. We did see an increase in pain, and that's because people were more awake, less delirious, and more able to describe that they were in pain, which is exactly what we want. We don't want them to experience pain. We want them to know when they're experiencing it so that we can manage it. And we saw reductions in ICU readmissions and discharges to facilities like nursing homes. A group in New York just published data on 4,000 patients showing that better compliance with the bundle reduced cost. And then there are the intangibles. We can't measure the benefit to a human being of having his family at the bedside as he's going through this. We can't measure, as Dr. Paikesh told me that day when I asked him, "What matters to you, Dr. P?" And he said, "I'm Buddhist and I want my monks there." And so I spent the afternoon getting him his monks. These are the intangible benefits of allowing people to be awake and alert and less delirious. And I'll close with a story from my patient John Baker, who had a myocardial infarction, a heart attack, and then got pneumonia. And while he was recovering, each day I noticed that he had a big book on his bed, but he wasn't reading it. And I said, "Mr. Baker, why are you not reading your book?" He said, "My glasses are broken." And I had forgotten to give him any glasses. He told me his wife would bring them to him, but she did not. So he began getting delirious. And I was worried, and I told the fellow, he's getting septic, I bet you, again. But he wasn't getting septic. He was having sensory deprivation. And that day, as he was getting profoundly delirious, I thought finally to give him the glasses that you see in my pocket. And the next day, when I came in, he was reading his book, taking notes, and telling me all about the different things he had learned in his biography of Roosevelt, not delirious anymore. And what a great lesson it was for me to make sure that I pay attention to that E part of the Dr. Dre, the diseases, drug removal, and environment. Environment, eyeglasses, hearing aids, light, sleep, mobility. These things are critical when it comes to reducing delirium. And I lecture on it, and I missed it myself. So interesting circumstance. By the way, he wasn't delirious, and he was able to tell me something important. If he had been delirious, I would never have learned that his father was in World War II, and that he wanted me to take his father back to Normandy. And as I was making a trip later that year to Normandy, I did bring his father back to the beach where he asked me to do that. He said to put him in the sand and write his name, John A. Baker, 93rd Infantry, and let the tide take him away. And so I did. And he now has these pictures on his mantle. And this is part of the relationship that we are privileged to enter into when our patients are critically ill, to find out what matters to them, whether it be Buddhist monks or bringing their father back to an important place where he ended up dying. These are my thoughts about the PADIS guidelines and how to apply them. I hope that you will listen to the other lecturers today and break it down in terms of pieces and figure out how you will change your culture to incorporate these data into the lives of your patients in your own ICU. Thank you so much for your attention.